because we have lab technicians here, this might be a little tedious, but I want to cover all the steps to do these prostheses. So I'm going to read the lab slips, and then you'll see it correlate when I show the picture. So I asked the lab to please scan the mandibular setup and design a locator fixed prosthesis. Measure the AP spread and make sure that the distal extensions are no further than 1 times the AP spread. So with traditional screw retain restorations, the AP spread, the cantilever can be 1.5 times the AP spread in general. With locator fixed, it can only be 1 times the AP spread. And that's just because screws give you a rigid connection and the inserts are not quite as rigid. And I asked them to design struts extending from the prosthetic to the land areas on both the buccal and the lingual to allow precise positioning of the prosthetic when picking the locator housing. So the prosthetic isn't going to have flanges that will sit in the model. So I asked them just to have these little fingers that go to the land areas of the cast and on the lingual. So when we're picking up the inserts in the mouth, there's something that stops it at the proper vertical dimension in the proper occlusal position that we've developed this whole time. And so let's talk about AP spread. So the way you determine AP spread is you measure from the distance from the front implant to the back implant. And as I said, with the conventional screw retained, you're going to have a 1.5 AP spread. So you can have a little bit longer cantilever. And the way that we improve that is that's why we tilt implants. We ask our surgeons to tilt implants, is to increase that AP spread and allow us to have a little bit more of a cantilever. That 1.5 is kind of a general rule, but it really isn't set in stone because it has a lot to do with, do we have nice long implants? Is the opposing arch natural teeth or is it a denture? What was the quality of the bone when the implants went in? Is the patient a bruxer? So all these things could influence where we might want to cheat a little bit or where we might want to be more conservative. For locator fixed, again, 1 time the AP spread. And with locator fixed, it's important, even though there is a 20-degree divergence that it will allow, the more parallel that we can get these implants for these cases, the easier it's going to be to insert and take out. And so that's another important reason to try to do guided cases. Yes, there are some surgeons that can eyeball and get these things parallel, but for me, I'd rather have a guided case anytime. So here's some examples over here where this is a good AP spread and we can have a cantilever back here. Over here, this is good here. This is bad, so we can't put as many teeth on this side as on this side. And you want to talk to patients about that because some patients are really like, how come my old denture had more teeth? And you don't want to just explain it to them after the fact. So the solution here is that you either have less teeth on that side or you see if you can add another implant to the mix so you can extend that arch form. Now, initially, well, let me put it this way. So with screw retained restorations, if you have an SRA abutment in here, and the direction was past that 20 millimeters, you wanted to parallel those implants. So they made a solution so that you could have a case that already had SRA abutments and maybe deep implants, and you would be able to put this abutment on to straighten out that implant and turn it into a locator fixed. That was invented before the most recent product, which is angled locator fixed. So now we have an angled locator of 15 degrees where we can get rid of the SRA and go directly to the implant in order to parallel those implants better. And Colleen, how long's that been out for? Like 6 months or so or more?
Yes. We introduced a few connections for the angled locator at the beginning of this year. We're continually adding
additional connections. We'll have an additional 4 here before the end of the year. So I'm going to touch on that right before our break because I have those connections available for you to be able to see.
But it's another reason to consider guided surgery because the lab and the cert can put it exactly at 15 degrees, those distal, if you want to extend the, the arch form of these prostheses. So everything will just fall into place if you do it in a guided fashion. And this is that prosthetic because it looks a little confusing, so I just thought I'd show this. Here's your SRA or MUA for systems other than Straumann, and then this slips over the MUA and the locator screws into the top of that. So it's a clever trick, but I think we can solve these problems more with the angled locators, unless there's an implant that's really off-center, and if it's deep enough, we can use something like this.
Can I say something, Dr. Deliberato?
Absolutely.
When anyone's ever placing that locator on the head, traditionally on your skin, your straight locators and on your angled locators, we defer to the implant manufacturer's recommendations for torque values. With that MUA, that torque value is only 20 centimeters. So I always, anytime we talk about an MUA and using the locator abutment on an MUA, that torque value is always 20 centimeters.
I learned something there too. Okay, and so the reason I go into so much detail, sometimes I think some people don't like as much detail, but the success of these cases is more dependent on all these little things in terms of case workup than just learning parts and pieces. And so a locator fixed course like this, if we were just talking about parts and pieces, we'd be here an hour, or two. So, and one thing that I don't like when I go to CE courses is when I see a practitioner who, in fact, maybe see them at several meetings and they show this great case and they show where they started and they show they were done, and then you have no idea how they got there. So this is why I kind of put this detail into my lectures for you. Okay, the next thing I'll say in my prescription is please schedule an online meeting to review the design before milling. Mill in Ivosian monoblock, and prior to applying the pink tissue, adjust the occlusion until the articulating pin is returned to the position established by the aesthetic wax try-in. Now, what I'm really saying is number one, before you mill the design, I want to see the design so I can approve. It's based on my wax up, but there's always little changes that can be made, made to approve it. So I call up Sam from the removal department. He almost always says, let's do it right now. He sends me a link. We go online. He's got the case up in front. I'm saying, move this. He might see something. I think this could be, and we collaborate together to get, the best design on the prosthetic. I asked to mill in Ivosian monoblock. So Ivosian, what you all would typically think is a digital denture milled in a block or a puck that has both pink and white. So the milling machine, they position the setup so that it's not teeth glued to a base. It's a one-piece digital denture. But Ivoclar also has blocks that don't have any pink in them. They're just all white, a certain shade. And because I was doing a conventional upper denture, I wanted to be able to match the shade to the upper denture and not just accept what the Ivosian denture gave me. So this prosthesis will be all white when it comes out, and then pink will be added after the fact. But before we put pink and we cut off all the struts, we have to pick up the locators on the model. And there was one case where somebody got the block that it was milled out of, cut the struts off, and we had to just do it all over again. So that's why I stressed to them before they put the pink on that we have to pick up the. Okay, next pick up the locator housings using the opposing wax setup. So we haven't processed the upper denture yet. We have the milled locator fixed. It's all white, there's no pink on it. We have the opposing setup. We put the models on the articulator, and we're going to bring that prosthetic onto the model to pick up the locator housings. And you'll see this, so it'll be less confusing in a minute. And then after the locator housings are picked up, they're going to apply this Braident Creoline, which is the pink material, to make it look like a denture. And then lastly, process the denture in IvoBase. And I wanted to wait till the end because once the lower was milled, I wanted to be able to go back and just touch up the position of the upper teeth so that all the cusps were in the fossas and all the teeth were hitting, because there could be some changes when you mill that prosthetic. And then I just let them know what the implant system is so that they know what they're dealing with. Okay, so here it kind of summarizes what I just read to you in the form. And one thing, anybody that would like a PDF of these slides, when we're done, give me your email address and I'll supply that to you so you don't have to write all this down. And if you want to look back at these workflows as you're learning on them, I'd be happy to share that with you. So here's the design of the lower prosthetic. The blue is my denture setup, and even though I know I'm not going to have teeth all the way back, by setting these extra teeth, it helps me get the teeth in the right position, because I know that the arch form should follow the ridge. I know it should be 2/3 up the retromolar pad. So I set those additional teeth just to give the lab extra information. And also when I'm trying it in, it helps me confirm the bite better to have all those extra teeth.